Hello, everyone. Um, Welcome to Equitable Practices, Engaging Patients in Collaborative Care. So my name is Monica Harrison. I am a licensed clinical social worker and former behavioral health care manager. I'm a clinical trainer and practice coach with the AIM Center. I have over 20 years working with all ages. My experience includes group homes, inpatient and outpatient mental health and substance use organizations, specialty medical settings and primary care settings that also have included hospital-based kind of private and FQHCs. I gained teaching and training experience working for Head Start, Early Head Start, and a joint venture master's program between a PWI, which is a predominantly white institution, and an HBCU, which is a historically Black college and university social work program that's in Greensboro, North Carolina. I've also been the behavioral health director over an FQHC, a collaborative care behavioral health manager over a large health system, and of course, a clinical trainer with the AIM Center. So I bring that to the table, but that is not the end all to all. I am a student of forever learning, and learning from others is what I love. So hopefully, gather some insight from you all today as well. As the speaker for today, I have no conflicts of interest to disclose. And after today's session, you should be able to describe typical collaborative care tasks and team roles, understand the evidence base for collaborative care, which that's kind of foundational setting. We have individuals joining today that are at different levels of collaborative care, from not sure what it is to we're doing it and how can we enhance and do it better. And you should also be able to describe core inclusive strategies for engaging patients in collaborative care. So let's set the stage. According to a national study conducted by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, only 40% of US adults with a mental health condition actually received treatment in 2021. And of those who do receive treatment, most receive their treatment in primary care. So there's a large national study that found that over a 15-year period, the proportion of all mental health visits that occurred in primary care rose from 54% to 60% primary care, where majority of the people received mental health treatment for a diverse amount of mental health conditions. So approximately 30 million patients have a prescription for a psychiatric medication in primary care, but only about approximately 25% of those have been shown to actually improve their symptoms. So a common solution for primary care providers is typically to refer patients for mental health services in outside organizations. So why not just refer? Because that's what we've been doing. There's two main reasons why referrals alone are not enough. The first one is patients tend to not follow through on referrals. There are two studies that have shown here revealed that approximately half of the patients receiving a referral for mental health services never followed through on that referral. The second challenge is that even when patients do follow through on the referral, the average number of visits was 2. And 2 visits is typically not a lot of time to have a big impact on the symptoms that someone is suffering from, or someone that may have a significant mental health problem. So one hypothesis about why patients don't follow through on referrals or don't continue care is that stigma, the stigma of going to a specialty clinic and receiving care there is uncomfortable. And so individuals will stay in their primary care setting where they have an established care relationship with their primary care provider. And I'm saying primary care, but we've also seen this happen in other specialty medical settings like oncology and cardiology and women's health. So what we've seen is individuals will stay in that established care setting that they have. They have a relationship built there. They feel comfortable there. So they'll stay there instead of taking the referral to an outside organization. So if a clinic wants to provide whole person team-based care to a
Mhm.
patient so they can have their medical and behavioral health needs met, we suggest an evidence-based model called collaborative care. So collaborative care is a systematic approach to integrated care. This slide shows some of the key features of collaborative care. So collaborative care starts with a primary care practice that has a integrated behavioral health staff member, personnel, provider, different words, different people use, but a behavioral health provider or clinician in it. The primary care team is supported by regular use of outcome measures, such as a PHQ-9, which looks at depressive symptoms, or GAD-7, that looks at anxious symptoms, which are used every time a patient presents for care to see if the patient is improving. They use a depression registry that helps clinicians track which of their patients are improving and which need changes in treatment. Uh, the use of evidence-based psychotherapies that are brief, structured, and appropriate to use in primary care. And they systematically review all patients who are not improving with a psychiatric consultant. So that is the premise of collaborative care. Now, there are 5 key principles that have been identified to drive effective collaborative care. The first is patient-centered care. So the patient, primary care, and mental health providers collaborate effectively using shared care plans that incorporate the patient's goals. The second is population-based. So that's where that registry comes in place that you use to facilitate engagement and outcome tracking. Measurement-based treatment to target is the third one. You're looking at progress, it's measured regularly, and treatments are actively changed until the patient reaches their clinical goal and it's achieved. The fourth is evidence-based treatments. So the providers are using treatments that research has shown to be effective. And then the 5 is accountable. The first 4 principles kind of lay the foundation for this fifth one. The care team is accountable to the patient and other care team members for the quality of care and clinical outcomes, and not just kind of the volume of patients they're providing services to. So collaborative care was first shown in an impact trial. So those who have been around for a while and used it for a while probably knew it initially as impact. And this led to better access to care, better health outcomes, and lower health care cost. So those are the main things that the trial showed. So that supported the positive results for the impact trial. It was more than 90 randomized controlled trials that have shown that collaborative care is more effective than usual care for common mental health conditions such as depression and anxiety. We have some of that evidence base on our website for those of you that kind of drives you. That is there for you to be able to get to and access and read. Collaborative care doubled the likelihood that patients improved, showing a 50% or greater improvement in their depressive symptoms. There was a systematic review of 19 studies published in 2020 that looked at collaborative care delivered to BIPOC patients, so Black, Indigenous, people of color, or people of other races. So the studies included 10 randomized controlled trials and 9 observational studies that all included those 5 key principles of collaborative care. One of the challenges they encountered is that there was no standard definition of what culturally sensitive care is. However, the review showed that collaborative care, even without cultural or linguistic adaptation, was effective at improving depression symptoms for racial or ethnic minority patients, including those that may have come from backgrounds considered low socioeconomic. So although most studies show that racial and ethnic minorities experience mental health conditions at the same rate as whites, there are significant disparities in access to treatments, in quality of care, and clinical outcomes. So addressing health disparities and access to mental health care is especially important as members of racial and ethnic minority groups in the US are impacted by poor access to effective mental health care. Notice the word effective. So delivering collaborative care in medical clinics that serve these populations represents an important opportunity to impact disparities as the collaborative that continues to come up and we hear about is around stigma. So we must consider the impact that stigma has on patients that are engaging in care. So there are some ways that collaborative care addresses stigma. The fact that collaborative care takes place in the medical office versus having to go somewhere new to a community mental health center or a private practice that they're not as familiar with, that actually helps reduce stigma with accessing treatment. This way, individuals don't know what specific focus that a patient is coming in for. If they're coming in because they're going to focus more on the mental health side of things, or is the patient coming in to focus more on the medical side of things? No one would know by the patient walking through the door. And at the end of the day, most places that are offering integrated care services are looking at the patient as a whole person care, because what we know is how a patient is doing physically can impact them emotionally, and how they're doing emotionally can impact them physically. So you want to be providing kind of that whole person care lens. The team-based care approach also supports whole person care instead of kind of the siloed services, fragmented communication. The goal with collaborative care is to have everyone on the team, including the patient, in the loop and in agreement with the plan. So having the patient as an essential part of the team advocates for the patient's voice to be continued presence in all aspects of providing collaborative care, further enhancing health equity principles of that patient voice being front and center. Collaborative care also helps to normalize behavioral health symptoms and treatment by taking a healthcare approach. For example, treating the PHQ-9 like it's a vital sign. So similar to taking a blood pressure, where you get that done every time you come for your visit. Get a PHQ-9 when you come for your visit. So that shows how mental health is just another dimension of health in general, that whole person care lens.
Monica,
Patient, oh,
I'm sorry, we have a question in the chat.
yeah.
Maria has asked, are these references you shared for adult populations only, or do they include pediatric literature?
So the ones that I was talking about in terms of the evidence that I showed was for the adult population. However, if you do go to our website, we do have some information there that's specific around studies that have been done in the pediatric population. There's studies that have also been done in, as I mentioned, oncology, the perinatal population. So you'll get more variety of what those studies showed if you go there. In terms of stigma and strategies, especially the strategies that I'll be talking about, those are for any organization providing care. With the pediatric population, you oftentimes also are considering the family as a whole. So when we're talking about patient, it's not just the patient in front of you, it's also their guardians. It could also include the school system and other individuals you might bring in to be a voice at that table for the patient's care. Now, with that being said, although in pediatrics, there's a lot more, or should be a lot more, attempts to include these other individuals from that child's community, please don't also underestimate the importance of that for adults as well. I'm oftentimes saying we look at that lens for the pediatric population and say, like, yeah, well, of course we're going to include their guardians because they're a peds patient and their guardian has to make the decision. Well, that's not the only reason to include the guardian or consider the school. Sometimes you're pulling in grandparents because you really
Mhm.
want to make sure there's the environment of individuals that that child is in, and that child is getting the support they need. So don't underestimate that for adults as well. So there are adults that, although I might not as an adult have a parent that's making decisions for me, but I might be engaged in my spiritual community based on my cultural background, based on many nuances, you might need to include my pastor or my priest or a shaman. So don't negate the opportunity to also include and ask adults who their support systems are, who helps them in their care, and including those individuals in. You might find that it's not always a family member, and I put that in air quotes because sometimes who people consider family, it could be extended family, it might not be biological family, but who they consider be their family and their support system can really vary. And so don't kind of X out including those individuals as well in a patient's care. So sometimes when I say patient, it very much seems very adult focused, and I am used to speaking adult focus, but I've also worked with a lot of pediatric patients and their families and their communities, and recognize that there's a common theme where at some point we feel like individuals age out and we shouldn't include the other people in the environment. Um, Hopefully I answers your question. If not, we will have a Q&A section at the end, so feel free to come loop back around to that. So patients often talk about feeling like there's something wrong with them when they're experiencing symptoms that they can't explain, or they don't understand. So patient education, psychoeducation, basically about behavioral health, is also an important aspect of collaborative care and can help patients increase their personal awareness of that mind-body connection. So how emotionally and physically things are impacting each other. So for instance, a patient might be referred to you for headaches and stomach issues. And upon further conversation and clinical judgment, conversation with the patient, people in their environment, the PCP might suspect, well, this is really anxious symptoms that are happening, even though physically what they're experiencing is headaches and stomach issues. So we need to kind of bring in that whole person care lens. Stigmatizing language, spoken and or written, has a significant impact on patient engagement as well. It can create negative opinions of the patient, and individuals then choosing not to maybe manage the patient's symptoms as aggressively or as appropriately as they should because of something that has maybe been written. So that written tone, even quotes and descriptions, could be stigmatizing. It could be patronizing and further emphasize negative opinions. So stigmatizing language, what I mean by that is, for instance, it might say the patient is resistant to receiving treatment or resistant to therapy or resistant to taking medications. That is really stigmatizing language. More helpful language would be the patient is not interested at this time and states they are not ready to engage in care because that's their choice. So the language we use, although we may think it is no big deal, you know, the people in the healthcare field are the only ones that are looking at it. It is a big deal. It can actually start to predispose ideas and create narratives that individuals can create based off of the written language that's used and spoken. And now that we have open notes as a law, more people are thinking about this in terms of what they are documenting and what they're writing in the chart. One of the things I always do is stop and think as I'm writing a message or a note, would I be comfortable saying this to the patient? Would I be comfortable with the patient reading what I'm writing? Have I already had this conversation of whatever it is I'm writing with the patient so that this is not new information for them when they look at it? And if you are engaging your patient and utilizing the patient's voice, then the less likely you are to write or utilize stigmatizing language in their documentation. So let's move to talking about specific strategies to enhance engagement. So here are some things organizations as a whole can consider to enhance engagement. So a culturally welcoming environment. Many of us have heard about diversity, where multiple identities are represented. We've heard about equity, where treatment access and opportunity are fair. And then we've probably also heard about inclusion, where thoughts and ideas of all are included. So DEI is sometimes what you hear short. Putting all of those efforts together is where you want to be. So putting all of those efforts together and centering that can create an atmosphere of belonging, which is what we want. We want individuals to feel welcome. We want them to feel like they belong in the spaces that they're in, and the exchanges and communication that they're having, that individuals feel comfortable being there. Another strategy is flexible hours of providing care, which is great for those who may have like caregiver responsibilities or work schedule conflicts. I know we are in the era of many individuals maybe working from home or working remotely, but we should not just assume that, oh, it's easy for someone to just hop on the Zoom because it's remote. That is not always the case. And we should not just assume that. There are conflicts that individuals could run into. And so making sure that we are being flexible with the hours that we are providing care, that we're building trust and rapport along the way, shared decision making, where patients are engaged in the decisions that are being made, whether by, if you're an organization that's making decisions, you might decide to have focus groups of patients that come in, and you have conversation about particular things. Many individuals use surveys to gather input from their patients. What I would challenge you with is to really go beyond that. Um, you know, beyond just focus groups or surveys. How are you really gauging patients? Are they a part of standard committees that you have that are meeting about particular things that you could then tap into their voice and have conversations with them and utilize their voice? My hope is, but I know might not always be the case, that individuals are also, if you are providing direct clinical services to patients, that you are gathering information from them and input about the services that you're providing to them directly, or from them directly. So just making sure that the patient's voice is a part of the decisions that are being made, not just the clinical face-to-face decisions of a patient's care, but also decisions that are being made about your organization as a whole that is there to serve that patient population. The best way to know if you're meeting the mark is to talk to the individuals who will tell you what it is that they need, who will tell you what it is that may be missing. So a lot of times we bypass that, or we say, oh, well, we gave a survey and not too many people filled the survey out. And then we just leave it at that instead of trying other means to gather information to get that patient voice, or diving into, well, what's going on, why no one wants to fill out the survey, and some of those things. So making sure there are opportunities for shared decision making throughout different avenues within your organization. You also want to address differences. So staff should be proactive in educating themselves about the differences between the patient populations that they're serving, their own narratives that maybe they tell themselves, what those are, and challenging those. Representation, we know, is definitely important. Having representation and culture of the populations you serve, but individuals on staff who can relate. Sometimes that means having peer support specialists or community health workers that are directly coming from the communities or the populations that you're serving. So we are starting to see more organizations incorporate these other staff roles into our care team. So consider that as well. And then, of course, addressing sources of any stigma that may come up that are blatant. Usually, if it comes up and you're seeing it, it's being mentioned, it's usually very blatant. But of course, we want to address and talk about those. And then, of course, people don't always think about the importance of focusing on wellness, and not just wellness for patients, because that's usually where it goes, as we think about wellness for our patients and are they doing well, and that's going to help outcomes and so on and so forth, but wellness for staff as well. It's a top-down situation. So we want to also focus on the wellness of our staff who are providing services to our population that we're serving. Their wellness is just as important as patient wellness. And so thinking about that welcoming environment, it also trickles up, not just the welcoming environment for patients, but also for your staff as well. So looking at organizational culture and what that is displaying or what that's speaking to in your organization for your staff is just as important. So this arrow is of the basic kind of collaborative care workflow. So starts, of course, patient engagement, establishing diagnosis, initiate treatment, follow-up care, treat to target, and then completing treatment and relapse prevention. So that's kind of the process that happens for collaborative care, an episode of care for a patient. So though engagement takes place throughout treatment, you're constantly engaging with the patient in different ways. It's especially critical in the beginning. So that blue highlighted area, when a patient is identified for collaborative care, that initial identification is often done by members of the care team, possibly using a screener or just patient's clinical presentation. So early in care, the role of that behavioral health provider on the team that we call the behavioral health care manager is to engage and orient patients to collaborative care specifically. So I want to go into core engagement strategies that are specific to collaborative care. So from that organizational lens we were talking about to kind of coming more in for clinic service delivery. So using a patient-centered approach to enhancing patient engagement, you should flex the needs and requests of the patient versus flexing to maintain parameters of primary care. So sometimes we say, oh, we can't do, like, this is the way we've always done it, but yet it doesn't fit maybe what the patient needs. Have you stopped to think that there are other ways to do it? How can we be flexible? Flexible in clinic, flexible maybe writing phone options, explaining collaborative care to the patient and the patient indicating their willingness to participate through informed consent is a great opportunity to then start to engage the patient in what they might need. So the patient, the primary care provider, the psychiatric consultant, and the behavioral health care manager will collaborate effectively as a part of the care team, and they will use a shared care plan that incorporates the patient's goals that come from the patient. So yes, there are evidence-based treatment options based on how a patient may be presenting. And so a primary care provider, psych consultant, the behavioral health care manager are going to pull from that. But the person that actually drives what's going to be in the care plan and what's going to happen in treatment is the patient. The patient has the final decision about their treatment, whether they like evidence-based brief interventions only. Maybe they might want medication only and don't want any brief interventions, or they might want both. There's some options in collaborative care. It's not one size fits all. So the patient gets to drive that on what they would like to receive as a part of the service delivery that your organization is providing. So whether through a warm connection where you're meeting the patient there in clinic, um, either in person or a telephone call, or at the initial assessment appointment, your ability to tailor how you also introduce collaborative care based on the needs of the patient in front of you is also an excellent strategy for engagement early on. So if I know the patient has already told me that they are not interested in doing, I've had patients say, I'm not interested in no counseling. I'm not interested in any of that. I've tried that. It doesn't work. I want no parts of it. So then when I'm talking about collaborative care, I'm not going to focus on that. They've already told me that they're not interested in that. So I would explain the collaborative care service that we provide overall, but then I focus on the other pieces that collaborative care provides that they may be interested in. The medication component of this, the management of symptoms component of this that might not include the brief behavioral interventions. So being able to tailor your introduction of collaborative care to the person in front of you and what their needs are that they've expressed to you is another engagement strategy. There's also a benefit of increased frequency of contact early on in treatment, and we've seen this throughout some of the literature that's there. at a minimum twice a month during that initial active treatment phase of collaborative care. Sometimes that means more effort on the part of the behavioral health care manager until the patient starts feeling better to do more contacts with the patient. There could be some barriers that come up to contacting patients, whether in person, they might not be able to come into clinic as often. And so considering what the phone contacts could look like, maybe there's a transportation issue and that's why they can't come in, or a scheduling barrier of some sort. So there could be lots of barriers to that. So you could consider phone contacts. Now, phone contacts doesn't fit everyone either. There could also be barriers to that. Maybe they run low on their minutes at the end of the month. And so you have to be mindful of that, considering maybe to contact them more towards the beginning of the month. So again, tailoring your actions of how you're providing care and the services you provide to the patient and what they need. You can also discuss visit options at that initial assessment with the patient, having those conversations about what barriers might get in the way. Frequent contact with the patient, ultimately, however you decide to do that, or however it's decided with you all to do that, is key for improvement. But we do want to reduce those barriers that might hinder a patient's ability to connect to the team. So again, whether that's transportation, sometimes it's childcare, some patients prefer texting. Again, if it's appropriate, works for your setting, HIPAA compliant, you got to make sure you meet all of your organization's rules. If it meets all of that, it may mean that you're doing more texting with some patients. So just making sure that the team is able to explore the usefulness of what works best for the patient portal. There's lots of different options out there now. So connect with the patient effectively to build rapport and also convey hope. You initiate intake from that first appointment. You don't want to wait an extended period of time to get an appointment for the patient or to get an available intake appointment. Sometimes our schedules are set up to where patients are having to wait 2 weeks. That impacts engagement. You want to be able to get the patient in as quickly as possible. Plan to gather information over multiple appointments. You don't necessarily have to get everything in that first visit. So have some discussion, get the things you need as a care team during that first visit. You can do chart reviews, review patient information, follow up with them in other ways. So be flexible in that. Ask about the patient's schedule and the best time for them to be reached by phone or text, or however you all have decided you're going to do that. You might have to gather multiple phone numbers, discuss frequent contacts, how that's going to be. You might have to schedule it, or they may give you Tuesdays are the best day, and it's a little bit more free flowing. As I mentioned earlier at the beginning of our time together, you want to discuss any potential barriers in advance of them happening. So if there's barriers with them arriving to their appointments, they need their appointments with you at the same time as their primary care provider or certain days, you just want to make sure you can discuss as much of that in advance as you can. And make sure treatment options that are discussed with the patient are aligned with what the patient wants, what their thoughts are, and it's documented and discussed with the entire care team so that the patient sees this is a team-based approach. It's not a siloed situation where only the behavioral health care manager knows that this is how this is going to go. So you want to make sure that it's a part of their care plan and it's documented in the chart effectively. So one of the things I mentioned earlier that can enhance engagement is your introduction of collaborative care. So I usually encourage everyone to have what I call an elevator speech, which is we think about riding in the elevator from the top floor down. It's not very long, usually, if you're in a good elevator. So you want to be able to describe and introduce collaborative care quickly. That's flexible. Whether you're describing it to someone that's in high level C-suite, a board member, something of that nature, that speech, elevator speech I give to them about collaborative care is very different than the one I give when I'm speaking to a patient. Very different than the one I give when I'm speaking to another member of the clinic about what collaborative care is. So you want to make sure that you can tailor your elevator speech to the population that you're talking to. making sure to explain how collaborative care is team-based and not a referral out, explaining the role of the care team members, and then of course setting expectation for what treatment can look like. When I kind of talked about there's different options of what you could get when you do collaborative care: brief interventions, medications, both. What are we talking? What does the patient need? Frequent contact, some of those things that will have to be discussed. So there are plenty of selling points for collaborative care that you can add to your elevator speech, but you do have opportunity to highlight specific aspects, as I mentioned, based on the individual that's in front of you. So for some, immediate access may be really attractive thing, that's what they want. So they might have to wait a really long time to get into traditional behavioral health. So that's not what they like. They want to be able to have someone they could talk to as quick as possible. So if you know that that is something that sparks the person's interest, whether it's a patient or you're talking to C-suite who's been upset about how long it's taken to see patients, then you want to tailor your elevator speech to address that. How does collaborative care address that? All of those things, again, help with engagement. Some people, it's frequent and cohesive communication. They want that. Sometimes individuals don't like to think about a diagnosis. They would rather you talk to them about the symptoms they're having and help with their symptoms. Sometimes that's the end or the focus, but you won't know that, again, unless you are having conversations with your patients or having conversations with your constituents. If we're looking at more organizational level, you know, a provider, if you're talking to a provider, their concern might be that communication hasn't been great. I'd like to know when I send my patient out for behavioral health services, what's happening, and I don't get to know that. So collaborative care might really speak to them because of the cohesive communication. It's team-based. There's communication that's free-flowing, the patient's involved, and all of those pieces. So just making sure, again, that you are able to talk to the group, stakeholder, constituent based on what collaborative care is and introduce that effectively to the group who's in front of you. Some patients are sometimes more willing to try something new if they know there's frequent assessment and course of treatment can change quickly. Some actually, I have seen, want to hear why collaborative care, like what's the evidence say, like why are you saying this is evidence-based, what does that mean? Sometimes we think that we can't explain those things to our patients, or utilizing that language is not going to be appropriate. I think you should try. You would be surprised. Some patients want to know, well, why? So why is this supposed to be more helpful? I'm going to improve my symptoms faster? Oh, okay. Well, which symptoms and what did it say? Some patients actually want to know that. So making sure that you can provide frequent assessment to patients throughout collaborative care, explaining to them what's happening with their symptoms throughout their course of treatment, because it can change quickly. You want to make sure that it's continuing engagement. You know, we talked about that heavy engagement on the front end, but it's continuous throughout providing services throughout their episode of care. So you want to make sure you're still keeping them in the loop. You're having conversation. It's still a shared care plan, even when you're updating it, even if there is a change that needs to happen, you still want to make sure that the patient is involved. So in closing, remember that collaborative care, even without cultural adaptations, was shown in the research to be more effective than usual care for behavioral health. Engaging patients in collaborative care and as key decision makers of their care is a health equity principle. It's important to be flexible to the ways in which communication
Yeah,
best meets the
but when I
best
was
meets the patient's needs and address barriers and stigma. And this includes considering multiple modalities and preferences that the patient may need. So you want to make sure that those are some of the things you just keep at the forefront. So I know we had a limited time today to try to at least put some principles out there, but we also wanted to give time for questions that anyone had. I call them sometimes aha moments, like, yep, we've experienced that. And then also talk to you about some things that are coming up through the Mental Health Association, Mental Health of America Houston, that could further evolve the things that we would hope to work with practices who want to engage in collaborative care on.
Thank you, Monica. I'm actually going to share my screen real quick so I can talk about our one of our program that we're going to launch soon. Are you still seeing my screen?
Yes.
Okay, awesome. So we're currently recruiting practices for one of our program. It's called the Breakthrough Series Collaborative Program. We will be working with practices who are currently in the process of integrating collaborative care into the practices and who are seeking additional technical assistance, guidance, and support to help them get through the implementation process, as well as, help them sustain it. So our collaborative program is going to be 12 months long. In that, we have, as you can see on the screen here, we're going to have 3 learning sessions. Each of the learning sessions are going to be focusing on different topics. The first learning sessions will be helping the practices to set their goals for their organization. Will also help you select changes that you want to implement in your organization. You will also learn about model for improvement, which will enable you to test the change ideas. Through that, you'll also be able to, by testing, reflecting, and learning and refining those tests, we'll also be providing you with the toolkits that will help you to document and track your data as you do those tests and see if they actually result in improvements. The second learning sessions will focus on how to accelerate your improvements. And then the third learning sessions, we're going to be focusing on holding your gains and spreading your improvements. So as you can see in between those learning sessions, we have action periods, and you can look at that more like a monthly reporting calls as well. And this is where you'll be testing your changes. You're going to be collecting your data, and we'll also be meeting monthly for coaching calls and also do one-to-one meetings. This is where the practices will also have opportunity to connect with our faculty member and get to have that one-to-one time, and in order to help you, give you more guidance and support where you need. So in this program, these are the areas we're going to be targeting. So we're going to be focusing on executive and practice leadership, clinical delivery, and financing and payments. So under each of these categories, we're going to provide a number of changes that you can select from that will work best for your organization. And then from there, we'll help you, guide you through the testing, how to test those changes, measures, and also how to help you implement them and help you sustain it. And for that, this program is actually going to be led by all of these amazing faculty members that you see on the screen here. You met Monica Harrison today for a little. She is the director of this program and also the chief executive officer for Concert Health, one of the leading person in the collaborative care realm, and has been known for her work in this model. Then we have Dr. Julian Mitten, and so he is a healthcare innovation leader and public health champion committed to advocating for improved and equitable care of, traditionally underserved populations. And then we have Dr. Laura Sidari. She is a board certified general psychiatrist with additional specialized training and experience in integrated psychiatric consulting. She has diverse clinical practice and leadership experience across military, college health, and community health settings. Dr. Sidari is the director for the Cayuga Integrated Behavioral Health, which makes integrated behavioral health services available to tens of thousands of patients across their organization. It's a not-for-profit primary care network in central New York. So with that, I will share the schedule very quickly. I mentioned earlier the learning sessions. We're going to have 3 of those. Our collaborative overall is going to be 12-month long. We're going to be launching this program in February. And so the 3 learning sessions are going to be held in February, August, and final one again in February 2025. In between those timeframe, we're also going to meet monthly. We're going to have monthly coaching calls, as well as the one-to-one meetings between the practices and the faculty member. So yeah, with that, I just want to put this up here in case if you are interested, please feel free to sign up today. If you have more questions, Victoria will follow up with email today and would be happy to connect with you and discuss this further. I know this was very short description of the program, but happy to meet with you separately and then talk more about this program if you're interested. So please, if this is what you need in order to help you integrate a collaborative care model into your practices, feel free to reach out to us.
So Gina, can I ask you one question that I
Yeah.
have been asked by a couple of people, so individuals on here may be wondering.
Sure.
What I have been asked is, do you have to be located in Houston?
No, this is all virtual. This is 100% virtual. You do not have to be located in Houston, and this is definitely not limited just to Houston either. Anyone from different state can participate in this program. I'll stop and open the field for questions. Feel free to unmute yourself or type in your questions in the chat, whatever helps you or easier for you, and I'll be monitoring the chat for questions as well.
While we're waiting to see if there are any questions, I would just say, because I recognize some of the names on here, for those of you who maybe are already effectively providing collaborative care service, and maybe you feel like, I don't know what I can get out of this or not, please reach out to Mental Health America and ask your questions or ask them now. They have been a great organization to collaborate with. I think it's a great opportunity. Also, if you're not interested, but you're like, oh, I know some other individuals who might, please share the opportunity with other people. We know that social networking is powerful. So we encourage you to share it with your networks because there's probably individuals out there who could utilize this opportunity. I know y'all heard her say the word free. So definitely share the opportunity, even if you feel like it's not for you. So there's a question in the chat box. Thanks for the question, Tracy. I think it's geared towards me. So Tracy says, when discussing involvement the patient has with the care team, are you having them meet with the team or just collaborating on their behalf? So I will say majority of the time, what I've seen, Tracy, is that the behavioral health care manager is collaborating on the patient's behalf. So there's not a I used to work in nephrology, and we used to actually have team meetings and would have patients come in quarterly. We would have patients come in to actually discuss their care plans. So it can happen because I've been a part of that, but in particularly in collaborative care, that behavioral health care manager is the one that is collaborating on the patient's behalf, sharing with the rest of the care team what the patient's wishes are, sharing that patient's voice when they're meeting with the psychiatric consultant, when they're meeting with the primary care provider or oncologist or whoever the medical billing provider is in your care team. So usually it is the behavioral health care manager that's collaborating on the patient's behalf. I do know that there are some programs that not routinely, but sporadically, if a patient is really having a challenge with something, things are more challenging than the patient would like, that there have been some systems that will have the psychiatric consultant and not just a behavioral health care manager meet with the patient. But again, that's not typical. It just depends on your program and how your program decides to operate and provide services.
No, well, we're launching this in February, so I would highly recommend signing up by January, the latest, please.
How can individuals, again, Sujina, I know that question was, is there a deadline? So there's not a deadline, but how can individuals sign up or register?
So we're actually going to, we have an application set up for this program. Victoria will actually send out the link to the application to all the participants here today via email. So that's one way to sign up for it. And then we're actually just, happy to take people on if they can just simply reach out to me, email me, and then however way we can make connections. But yeah, we do have an application and a link that we will provide to all the audience here today. Any questions for Monica?
Well, that just means they received the bit of information that I gave well.
Okay, I think we don't have, I don't see any questions in the chat either. Well, if there aren't any questions, then thank you all so much for joining. We have set up some other webinars as well. We'll be sending out more information about that in upcoming days. Victoria, do you want to close us out?
Yeah, so as Sujina mentioned, I'm going to be sending out a follow-up email after this. And so that's going to include Monica's presentation. It's going to include a recording of the session as well as the application for the Breakthrough Series if you are interested, and also the next training date if you're interested in that as well. Thank you so much. Have a good day.
Thank you. Thank you, Monica, so much for your time today. And